Let's talk a bit about intention to treat analysis. This is essentially the gold standard of analysing results from a clinical trial. In intention to treat analysis, all participants originally randomised are included in the analysis and are analysed according to the group that they were originally assigned to. This is regardless of factors such as if they actually received the intervention, how much of it they received, how much they adhered to it, or if they dropped out or were lost to follow-up. Let's take an example of a randomised control trial, which compares the effectiveness of drug A versus placebo on LDL cholesterol levels over a 6-month period. We have 100 patients who get randomised, 50 of them to drug A, 50 of them to placebo. However, during the 6 months, 5 assigned to drug A dropped out or were lost to follow-up. Applying the intention to treat analysis, all 50 patients who were originally randomised to drug A are included in the final analysis, even the 5 dropouts. Now, what are some of the advantages of this? Intention to treat analysis preserves randomisation. By maintaining randomisation, the analysis provides a more unbiased comparison and maintains an even spread of baseline characteristics. It must be said that intention to treat analysis gives a more conservative estimate of the effect of the intervention, because inclusion of those non-adherent to the treatment or those who drop out tends to dilute the treatment's apparent benefit. Let's have a look at how it preserves randomisation. We took the 100 patients, we randomised them to drug A with 50 patients and placebo with 50 patients. Imagine that all 50 patients continue with placebo throughout the trial. However, 5 of those assigned to take drug A were deemed too sick to carry on taking drug A, and therefore were removed from the trial. In removing these sicker patients from the trial, now the group of patients taking drug A are on average inherently fitter. Let's compare intention to treat analysis to per protocol analysis. In per protocol analysis, the 5 non-adherent to protocol are excluded from the final analysis. So only 45 out of the original 50 in group A would be included in the final analysis. This can create bias and ruin randomization, as we've seen on the previous slide. Per protocol analysis can also hide potential real-world problems with the intervention that may have led to these 5 dropouts. There may be potential important reasons for the lack of compliance or non-adherence to protocol. These could be intolerable side effects, a difficult or perhaps hard to stick to regime, perhaps even death if some participants are completely lost to follow-up. I hope you enjoyed this video on intention to treat analysis. If you have any suggestions for more videos, let me know in the comments. Like and subscribe and stay tuned for the next video.